Choice Home Care and Hospice present Choices to Benefit the Aging with your host, Joe Urrutia.
Welcome to Choices to Benefit the Aging. I'm Joe Urrutia, Community Senior Service Coordinator for Choice Hospice and Home Health. Today's topic is diabetic foot care. Our guest is Dr. John G. Taylor. He's a podiatric surgeon, board certified for wound care, foot surgery, and again, our topic is diabetic foot care. Welcome to our program, Doctor.
Thank you for having me.
Please give me an explanation of foot podiatry or
Podiatry is a specialty that is mostly associated or, limited to the lower extremity. We do screen for upper extremity, as far as when it comes to circulatory disease, but we treat the foot and ankle as a whole. The body is a whole, and you can't just treat one thing. Podiatrists are trained. We go to 4 years of med school. And then we go to residency after that, and depending on what you like, you can go into different areas of specialty. The one that I chose, which I liked the most, was wound care in diabetic population, and also surgery. You do that and you find out what you really like. It's not a field for everybody. There's a lot of specialties, not just podiatries in town. Internal med, a lot of different docs are going into wound care, but really wound care, I believe, really started with the podiatrists, because we were the ones that initially saw the ulcerations and the what caused those ulcerations, and how diabetic foot progresses to a point where it gets to a point where eventually bad things happen to it.
It seems that you're very well-rounded, also having your specialty in wound care and as a surgeon. Mm-hmm. Is that what people should look for when they're looking for?
Yeah, it's very
physician?
difficult. There are varying degrees of physicians in any specialty. Some, for instance, let's just use family practice, internal medicine. Some of those guys only like to do certain things, and some like to do others. It's the same in podiatry. Some of my colleagues, they want to do ingrowns and bunions and things like that. And my area that really gets me excited is doing wound care. My focus is, since I am, I guess, a wound care specialist and a surgeon, is I can offer patients more than one thing. So let's say they come in and they have an ulcer. Well, my treatment's not going to just stop with an ulcer. If we have to go to that next step, then I can employ some type of surgical procedures to either help them or, prevent further progression of the disease.
I want to talk about now diabetes and how it affects the feet. Can you go into more detail on that? Yes,
it affects the feet in many numerous ways. I have patients just walk into the office and, I can literally look at their feet and tell you what's going on. But the two main primary causes or things that diabetes does to the feet, it affects circulation and it affects the nerves. The nerves are just as, each one is both important, and sometimes you can have a mixed problem. In other words, you can have both arteriovascular disease and also a nerve disease. Each one of those problems will set you up for ulcerations, infections, and gangrene, and all the amputations that come with that.
What is checked on the foot?
When a person comes into my office, the first thing I do is pretty much laying hands on the feet, and I'm checking pulses. To me, if you don't have blood flow to the foot, it's not going to heal. So if there is any type of ulcerations, you really got to worry about, well, is this guy or is this patient going to heal? So I'm thinking ahead when I'm looking at that, and it's no different than a plant. If you don't give water to a plant, it's not going to grow. The second thing I look at is hair growth. I look at the skin texture, turgor. Is there any ulcerations? Has there been a history of ulcerations? Hair growth, if I didn't say that.
Why hair growth?
Hair growth, the same thing. It's like a plant. If you don't have blood flow to the lower extremity and the hair growth is limited, then you got to start thinking, well, there's probably some type of nerve disease or vascular disease going on. So there's a really, I mean, the whole exam would take usually about 15, 20 minutes just to look at that part.
Who initiates the referral? Is it their internal medicine, primary physician, or can they go straight to you?
It depends on the insurance a lot of times, but we do get a lot of referrals from internal med doctors, family practice. We get people coming to us at the wound care center. I'm a wound care director at one of the facilities in town, and we get referrals from people that they'll try certain treatments, they're just not getting anywhere, and so it's kind of last resort. They punt them to us, and that's we try and treat them appropriately.
Yeah, I'm sorry to deviate from the questions that I was about to ask you, and just because that was kind of important, because patients or just the clients and the public wants to know, do I go first to my internal medicine or to a physician? Can they go straight to you?
That's hard to say. If you have a good relationship with a podiatrist already, and they are familiar with wound care, then go to them. Obviously, you got to follow up with your primary care. That's to them. If their sugars are not well controlled, then they're not going to heal very well on the bottom of their feet. There's other areas or other types of specialties that like to do what I do as well. So sometimes I will have my patients go to other physicians. I send a lot of referrals to cardiovascular. I keep well in touch with a lot of the doctors that send me, just so they know what's going on and where we are headed. One of the things that I wanted to bring up, and we kind of touched on a little bit, is etiology. And what etiology is how did these problems start? In other words, how did I get this ulcer? And what's causing it? And the main thing when you see an ulcer or an infection or anything really looks suspicious in diabetic foot, you've got to determine what caused it. Was it from pressure? Is it from the diabetes? Is it an arterial ulcer? I mean, there's at least 4 different types. I mean, there's decubitus ulcers, which patients are familiar with. Those are just basically bed sores. But then you top that on with diabetes or circulation disease, then it makes it a little more complicated to treat.
Okay, so now a patient goes, the doctor, primary physician has recommended to you, they go to you. What goes on with, what do you look for in an exam, and what tests are done?
Well, first thing, let's say they come in with an ulceration. I'm going to look at, what type of ulceration is it? How deep is it? That means a lot. Is it a superficial one? Is it a deep one where I can see bone? I'm also going to look at their varying things like, do this patient has circulation? Right away, I'm going to consider some type of vascular study, whether it be, you don't call it a screening tool, but an ABI, which checks out blood pressure changes. If I feel that it's past that point, I would send them for an arterial Doppler. Once I got the results back, if they just show any type of blockages in the legs and feet, you got to instantly get them into cardiovascular. Now also too, there's another area that, a lot of these patients, they're very, very sick, and they may have kidney disease as well. So you got to always think about the nephrologist as well. Include him in on the treatment, and that's very important.
Why are the feet involved?
Diabetes is one of those progressive diseases that just get worse and worse. When I was in school, they told me pretty much diabetes affected every system in the body except for the hearing. But there are some areas that it likes to affect most. Number one is the cardiovascular system. You can get blockages in the big vessels, small vessels, kidneys, that's a big thing, eyes, and feet. And those are the areas where you can actually, if I have a patient come in and I'm literally not looking from the knees up, I can tell you whether or not that's a diabetic foot.
What are the first symptoms that you would advise a family member or a client to look for? From clipping their own toenails, if they cut themselves and they don't see healing, what is your advice?
Well, I think, if they do have diabetes and it is, they're being followed by a primary care doctor.
Not very quick, if they have diabetes and if they're on insulin or they're taking PO tablets, which one is more susceptible to?
To me,
Both of them?
they're both bad.
Okay.
I mean, juvenile diabetics type 1s in the past, you know, they didn't live as long. Their bodies basically didn't produce insulin, so their sugar levels were always up. As you get older, we start developing more diseases, and the longer you live, you develop what's called age-onset diabetes, or type 2. Now, you know, we all like to eat all the good foods, and the longer you have those blood pressure or blood sugar levels increased, it's going to cause damage to a lot of the systems, and the eyes, the kidneys, and the feet, and then especially the nerves. It's going to damage that. You have higher glucose levels for a longer time, and people don't seem to understand that they think they're feeling fine, but their glucose levels are out of control. And a lot of times patients, you know, will say to me or say to their primaries, oh, I'm not going to take the pills, I'm not going to take insulin because that's what's causing my problem. And they don't understand that, no, that's not your problem. Your problem's diabetes. These medicines are meant to help you, and they're meant to control the sugar much better so that that increased sugar levels doesn't keep causing more damage to the systems in your body.
So you strongly recommend patients that are taking out their tablets still be very aware of their foot care and...
Yes, they need to be vigilant on all areas. I mean, especially, let's say, they're not very good at checking their sugars. If they come into me and they say, you know, they have an ulcer, or if they got gangrene, or whatever they got, if they're not taking care of those blood sugars, it's harder for me to treat because their body itself cannot mount an infection or treat that because the body's trying to worry about other areas. And because the body is trying to fix or you know, basically keep itself alive, the feet are the last, that's the last thing on the list. And you always hear patients talk about, oh, my friend had this amputation, they just kept going up and up and up. Well, the reason is, you know, because of the diabetes. It's going to affect the toes usually first, the forefoot, and what it does is it affects the nerves and the circulation, and so you can't tell what's going on. It's almost like a silent disease, and people think that, no, I feel fine, so nothing is wrong.
Again, I want you to tell us, if I have a family member, if there's patients out there, they're diabetic, clipping, or their toenails, they cut, again, what are the symptoms that they should look for and they should be alarmed of saying, it's not healing, the redness,
yeah,
the
any
swelling?
cuts that aren't healing, you want to look at hair growth. I mean, does the hair growth stop at like half the leg? Do you not have any hair? I mean, is the leg entirely void? You may see color changes in the legs, which is common. Wounds or cuts that don't heal.
Can the feet be, can they look for cold or feet or warm?
Yeah, you can feel whether it's warm to cool. That's another way. You should inspect your feet really every day. And if you are more of what we call a brittle diabetic, one that has kind of went to that next level, then you should.
So what is the inspection, when they're inspecting their feet, what do you want them to look for?
Any changes.
Okay.
You know, anything that doesn't look normal for them is a good thing. Any new, I mean, sometimes even in the nails you may get infections. Something as simple as an ingrown infection can turn into something where I have to admit the patient. I've seen diabetics develop active infections in 24 hours, and I've literally had to take them to the hospital and admit them right away, and we went right to surgery.
Can patients be compliant, the ones that are compliant with their medication as far as their insulin or their PO medications, are they less susceptible to getting infections, or do you still think they're still high risk?
No.
Versus one that's not non-compliant?
Right. The non-compliant patient, you know, it's almost like a disregard. So, you know, they almost don't care about, you know, I'm just going to do this and whatever happens, happens. And then woe is me. But those patients that do regulate their sugars constantly, they're going to live longer, they're going to have a better quality of life, and they're going to have less complications altogether.